This is a presentation of shockwave lithotripsy. It's a basic theory presentation. Again, we apologize for those who are already knowledgeable in the field. We're doing an overall training here. We begin with a small introduction on the urinary system and the formation of urinary stones. The urinary system consists of kidneys which produce the urine after cleansing the blood. The urine is then passed down to the bladder through the ureter. It's a symmetric system. We have a kidney and ureter on each side of the body, left and right. The kidneys are located closer to the back, and the ureter is passed towards the bladder, which is down in the pelvic bone towards the front of the body. The bladder is then drained through the urethra. Here's another more detailed explanation of the urinary system. The ureter itself consists of upper ureter, middle ureter, and lower ureter. The upper ureter is located closer to the back of the patient, and the lower ureter closer to the front of the patient. Most of the stones that you will find are located inside the kidney. Some of the stones then migrate down to the ureter and then down to the bladder. This is a cross-section of the kidney. The kidney basically consists of 4 areas: the upper, middle, and lower calyx, in which you can find the stones, and of course there is a renal pelvis, which is the junction that leads to all the calyx. The ureter, then you can see on the bottom left side of the picture, leads down to the bladder. Urinary stones are formed when the concentration of urine is too high. Then the crystalline structures begin to form and to increase in size. Of course, the more time you wait, the more the stones grow, and the more the treatment becomes urgent. So most of the stones will start out in the kidney and will migrate down to the ureter. Stone sizes vary. You can find stones anywhere from a few millimeters up to a few centimeters. Most stone sizes range up to 2 centimeters. Lithotripters are meant to deal with stones up to 2 centimeters in diameter. Any stone bigger than that may require some additional options, such as a laser. Here you have a small background on the formation of stones with respect to both the patient and the climate. The males are more likely to have kidney stones than females at a rate of 3 to 1. And most people will have kidney stones before the age of 50. The vast majority of patients will only experience 1 kidney stone in their lifetime. Those patients which have a proclivity or have a habit of forming stones will have to come back very often. That is, but usually patients only come in once in their lifetime for a stone treatment. The importance here is to drink a lot of water, because the stones are formed through a high concentration in urine. So if you drink a lot of water, you can decrease the likelihood of having kidney stones. Climate and geography. We have a question about Staghorn calculus. I will come to this in a minute. The climate and geography. Usually in dry areas, of course this is related to the water intake, dry climates have, of course, cause a higher incidence of stone formation. Here is basically a split of the different types of stone that will be found. Most of the stones are calcium-based. They're pretty easy to break. Some stones are more difficult to break, like the cysteine and calcium phosphate, and those you can treat, for example, with a laser. But ESWL is valid for the large majority of stones. Of course, the harder the stone, the harder it is to break using shock waves. There was a question concerning staghorn stones. The staghorn stone is basically a stone that was let to grow for a very long period of time and started forming inside the kidney. And staghorns are called that way because of the horns of the stag, which is sort of a deer, and they don't have a round shape. The staghorn stones grow to a very large size and have to be treated most of the time using PCNL with a laser. Here you have an example of uric acid stone, which is radiolucent. It cannot be seen with an X-ray, and thus the treatment of stone will require sometimes the coupling of both X-ray and ultrasound. So the stones vary in size, anywhere from a few short millimeters, 1 to 2 millimeters, up to much larger sizes, sometimes several centimeters in diameter. As I explained earlier, stones pass down, sometimes migrate from the kidney down the ureter. Usually if a stone is 4 millimeters in diameter, it will be able, or less, it will be able to pass down the ureter down into the bladder. If it is more than 4 millimeters in diameter, it will get stuck in the ureter, and thus will have to be treated in that area. The frequency of stones, as explained earlier, depends on the region and climates. Here are some examples of prevalence of stones. Stones are very prevalent in the United States, in Europe, much less in Asia, or in Africa, for example, where the prevalence is much lower. The symptoms of urinary stones are very severe pain, sometimes hematuria, which is blood in the urine. The patient may experience nausea and vomiting, and painful urination, as well as an increased frequency in urination because of the blockage caused by the stone. These are some of the possible consequences when stones are not removed. They can cause obstructions, and here you see hydronephrosis as an example, when the pelvic junction starts increasing in size and starts damaging the structure of the calyx, the upper, middle, and lower calyx, which we saw. If a stone grows to a large enough size, it may actually cause permanent damage to the kidney. Of course, usually the prevalence, say, poorer countries will see patients wait a much longer time before they go seek treatment, and thus the stones will be much larger in size, which will result in higher likelihood of damage to the kidneys. Here are some of the other consequences of untreated stones. Perforation, for example, if a stone is stuck in the ureter, if it is sharp, it will cause a perforation. It will cause scarring and urosepsis. Okay. Now we will get into the diagnosis and the treatment of the stones. Let's begin first of all with the imaging methods. Sure. Here you can see the standard kidney uretary bladder X-ray. On the top left you can see that there is a formation of stones, which are very visible through X-ray. As a very dense structure, they appear white. Here, in the second picture from the left, you can see that there is the possible use of a contrast material in order to locate a stone, which is radiolucent. If the stone cannot be located through X-ray, you inject the contrast dye, and thus the areas which are not filled with the dye represent the areas where you have a stone. You can also use a CT. The ultrasound has been very popular lately in the location of stones. It is used, most clinics and hospitals will use both an X-ray and an ultrasound to facilitate the location of stones. As explained, stones can be radio-opaque or radiolucent, and the ultrasound will help the localization of those stones. So, for the past 30 years, ESWL has become over the 80s and established itself in the 90s as the gold standard for the treatment of stone. ESWL means extracorporeal shockwave lithotripsy, which is a non-invasive method for the fragmentation of stones. Here you can see a picture of a modern system, our very own Magna Duet, which is an electromagnetic system. What is a shockwave? A shockwave is a very strong and very fast buildup of energy, usually discharged by a large capacitor. The characteristic of the shockwave, which is a pressure wave, is a rise time, a buildup of pressure in the order of nanoseconds, and then a fall time that lasts a few microseconds. So as you can see, it's a very, very fast and very strong wave. The pressure for this kind of shockwave varies anywhere from 300 to 1500 bars, depending on the technology that you're using. Shockwaves can be observed in our modern world in many ways. Here is an example of a sonic jet actually passing Mach 1, so breaking the sound barrier and causing a shockwave as he does so. The purpose of the shockwave is to travel through the patient's body until it encounters the stone. When it encounters the stone, there is a reaction with the stone itself. The shockwave will partially reflect off of the stone and partially refract into the stone, and gradually provoke fragmentation. There are three forces that cause the disintegration of stones. The first one is a direct force, the impact of the shockwave on the stone itself. The second one is erosion. You have shockwaves which are reflected off the surface of the stone and that head back towards the generator. And the rest of the wave is transmitted within the stone and then will bounce inside the stone from the interior wall to the exterior wall. The third process, and a very powerful process, is cavitation. It's the formation under pressure of gas bubbles, which then collapse and cause erosion of the stones. Now, as you treat a stone, you cause fractures inside that stone. Thus, you allow water to penetrate inside the cracks of the stone, and the effect is magnified with time. Usually, a stone will require anywhere up to 2,500 to 3,000 shocks in order to fully disintegrate it. Here is an electrohydraulic parabolic reflector. As inside the center you can see a spark gap. This is the first technology to have been developed for the disintegration of stones, the electrohydraulic one. We will go through all these different technologies at the end of the presentation. The spark is generated at F1, focal point 1, and the reflector, which you see in the silver reflector, will focus all this energy onto a second focal point. Here is the theory behind this. If you generate on the left side energy at a focal point F1, and this energy then bounces off the reflector, which you can see outlining the left side of the picture, all of the waves will converge onto F2, as you can see from the arrows. This allows for a buildup of a lot of energy onto one single focal point. Now, on the left side you have the reflector with the generating point, and on the right side F2 is located where the stone is supposed to be located. This way you approach the transducer to the body of the patient in a way, using the imaging, that the F2 is located where the stone is located. And this way you are non-invasively creating a buildup of energy at the stone's location. As explained earlier, the shock wave is a pressure wave. You can imagine a stone falling into a pond and creating ripples. You have an initial impact, which then creates the transmission of energy through the water medium, which is seen in the form of waves. An important characteristic of the shock wave, or any wave for that fact, is that the shock wave travels through a medium uninterrupted, which means if you generate a shock wave in water, it will continue propagating in this water uninterrupted. If you generate it on steel, for example, and you can imagine a train traveling on train tracks, you can put your ear to the train tracks and hear the train coming from kilometers away. This is the principle of sound propagation within a uniform medium. Here, if you take the same scenario where you generated a shock wave inside a water medium and you place a stone inside this water medium, the shock wave will will react with the stone, because the stone's density is different from that of the waters, and thus there will be a reaction. The procedure itself for the treatment of urinary stones goes as follows. First, the patient lies down on the table and is connected to the ECG monitor. You connected him to the ECG monitor because in order not to influence the cardiac rhythm, you have the option of timing the shockwave treatments with the cardiac rhythm. The stone is then located using X-ray, ultrasound, or both, and the treatment is usually carried out, but this depends on the region in the world, using anesthesia or analgesics. Some countries will choose to bring in their patient fully asleep, and some countries will just administer analgesics. Once the stone is located and is placed at the focal point F2, so you have to change the position of the patient in the XYZ in order to make sure that the stone is located at F2 with respect to the generator, which is not moving. As explained, the shockwave is generated inside a water medium, and because the water is mostly water, the body is mostly water, then if you generate a shockwave inside a water medium and transmit it to the body, which also consists of water, then you have an almost uninterrupted energy propagation. So for this, all shockwave generators today have a shockwave source located inside a water medium, and this is allowed through the use of a membrane. The membrane is filled with water and then placed against the patient. There is a contact gel which allows for to avoid air bubbles and air pockets between the membrane and the patient's skin, and ultrasound gel is usually used for this application. And then you're able to generate shockwave from the membrane, from inside the membrane, and transmit the energy inside the patient's body. You can couple the patient using gated and non-gated shockwave in order to adapt to the cardiac rhythm of the patient. Usually, a stone will break with less than 3,000 shocks. In some countries, this amount of shockwaves is regulated. For example, in the United States, they allow only up to 2,400 shocks before you have to interrupt the treatment and the patient will have to come back. The imaging, of course, is used throughout the treatment to assess the fragmentation of the stones and also to see if they have not moved. If you are treating a stone with shockwaves, you may influence its location, and you may want to follow up on the stone's location in order to make sure that you are aiming the energy at the stone and not at the soft tissue. The coupling mechanism, as explained earlier, consists of a membrane. Okay, the energy is transmitted from a water-filled medium through the membrane, through ultrasound gel to the patient's body. The patient's location is of course adjusted with respect to the generator. F1 and F2 is a fixed parameter. Now when you develop a shockwave lithotripter, any company has to basically give the parameters of the device, and that's the distance between the shockwave source and the shockwave destination. So the patient has to be positioned with respect to the generator, and this you can do by controlling the table, which is usually remote controlled. Here you can see a very good example in the left side picture of a patient, of the coupling of a membrane with the patient's skin. As you can see, the patient's skin is a bit shiny. This is because you apply the ultrasound gel to avoid any air pockets, air formations. You can treat a kidney stone from a number of positions depending on where the stone is located. If it is located in the kidney, you can treat it from the back using back coupling, or you can treat it from lateral coupling from on the lower end, as you can see in the left picture. This way you are close as possible to the stone. Some devices allow you to have a rotating generator, which allow you to target the stone either from the lower side of the body or the upper side of the body, depending if the stone is located in the lower ureter near the bladder, or the upper ureter or the kidney, which is closer to the back side of the patient. ESWL is considered as a relatively safe treatment. In part, this is due to the fact that the number of shock waves required go up to 3,000, and there are not many cases of severe adverse events. The most common ones are hematuria, blood in the urine. This is caused by the fact that the shock waves affect not only the stone but the soft tissue surrounding the stone. This, of course, is in the case of minimal damage. Some much less common is cardiac arrhythmia, but this can be avoided using ECG gating. Sometimes when you fragment a kidney stone, the fragments may migrate down to the ureter and cause a wall of stones, which is called Steinstrasse. This can be treated with a laser if this happens. Some of the other adverse events are nausea and vomiting and urinary tract infections. The least common but most grave adverse events that can be reported is the hematoma. If too much damage has been dealt to the soft tissue in the kidney, then this may cause sometimes permanent damage to the kidney, and in the worst cases will require the removal of the kidney. There has been a device in the past from company Storz, for example, which had a very high incidence in one of its devices in the past. This incidence of 3 to 4%, which was unacceptable. Of course, our Duet Magna device has a 5-fold kidney reduction, which means that a very low, there's a very low chance, actually the lowest chance possible for such hematomas. On to the explanation of the focal area. The most important feature of any lithotripter is the focal area. Now, as explained earlier, the energy is transmitted from a focal point F1, reflected off the reflector, and transmitted to F2 in the body. This is more of an ideal transmission from point to point. In reality, the energy is generated in F1 and lands in an area around F2. Now, the size of this area is what is really important. If you have a very large area, this is we can use the analogy of a hammer, where the energy of the impact is distributed over a larger area. If we take the analogy of a very, very small focal area, almost point-like, we can use the nail as an example for that, and this we will see in the coming slides. If you hit a hammer with a stone with a hammer, you will be impacting the entire volume of the stone, and thus you will be fragmenting not a specific area but the whole stone, which is considered efficient. As for the soft tissue, here you have a rubber ball in the lower end. Now the rubber ball is representative of the soft tissue. If you hit a rubber ball with the hammer, you can expect the hammer to bounce back. This is approximately what happens to the soft tissue. If you generate a shock wave and it arrives on the soft tissue over a large area, then there will be minimum effect of this energy on the soft tissue. On the other hand, if you have a lithotripter which generates a small focal area, a very, very small focal area, and all the energy is concentrated over that small area, then when you look at the stone on the top side, on the top picture, you can see that the fragmentation logically will only happen over that specific area where the energy is delivered. So you're only fragmenting essentially part of the stone, not the entire stone, which will not lead to an efficient fragmentation. This is regarding the stone. Regarding the soft tissue, if you take the same analogy with the rubber ball, if you plunge a nail into a rubber ball, you will pierce the rubber ball. It will not bounce back, as in the hammer. And the analogy here is used to explain that if you have a very, very small focal area, then if this area reaches the soft tissue, then the damage to the soft tissue will be much greater. The lesson to be learned here is that if a lithotripter has a large focal area, it will both provide better fragmentation for stones and lower kidney damage. Here is a representation of the focal area with respect to the kidney stone. The focal areas are usually a few millimeters to a centimeter in width, so from top to bottom in this picture, to a centimeter and a half to several centimeters in length from left to right. So if a stone is located, let's say, near the aprocalyx, as you can see in this picture, you can provide a very good stone fragmentation and lower kidney damage if you have a very large focal area. So this is a summary. Small focal area is bad, large focal area is good, essentially. This is the last part of the presentation, and is very essential to understanding the different types of technologies and their advantages and disadvantages. There are essentially three types, and historically you can see on the left electrohydraulic. It's a spark gap principle, a generation of high current between two electrodes. It is similar to lightning. You generate this. This was the first technology to be used in the early 1980s, and is still considered to be today the most efficient way to fragment stones. This is especially due to the fact that the electrohydraulic technology provides a very large focal area. As we just explained, this is the most efficient for good stone fragmentation and lower kidney damage. Later came in the electromagnetic generators, which allow you to use which operate at lower energy levels, which allow you to treat the patients with less sedation, and nowadays with no sedation, and but also come with a disadvantage, which is the smaller focal area. The piezoelectric on the right is the least used technology, today only used by one company. It is not a popular technology and has not really had much success historically. So the main two technologies to be seen in the markets today are electrohydraulic and electromagnetic. As explained earlier, you have on the right side the generation of a shock wave at F1, which is reflected in this dark elliptical shape, the reflector. All the waves converge onto F2, which is where the stone is to be located. Here is a picture of an electrohydraulic shockwave head. This, you can see there's a spark gap, the small white shape inside the reflector. High current is run through this spark gap, and a spark is generated from within a water-filled medium and is transmitted using the reflector onto F2. The advantages of the electrohydraulic technology are a very large focal area. We're talking 13 to 15 millimeters in width, which is enough to cover most stones. As you remember, many stones range from a few millimeters up to 2 centimeters in diameter, and thus you would ideally wish to have a large focal area to cover the entire area of the stone. So you will require in that case fewer shocks to fragment a stone. You will have thus a lower retreatment rate, lower patient comeback, and you will have fewer side effects because, of course, you're causing less damage to the soft tissue. It's a very simple technology, a lot of experience, and also the generators last a very long time with this technology. The disadvantages are that the spark causes a lot of noise and also requires high levels of sedation. It is considered a painful treatment, and in most countries the patients are put to sleep. One of the disadvantages is that there are consumable electrodes, which means that you have to replace the electrodes every few patients. The electromagnetic technology uses a magnetic coil to generate an electromagnetic wave. As in the electrohydraulic technology, the electromagnetic wave is generated at F1, where you can see the coil in the middle. The energy is reflected off the reflector, as you can see, onto a point F2, which is in red in the picture. There are two ways to generate this electromagnetic focused wave. One is using the same principle as a speaker. If you generate a wave and use a membrane to generate this electromagnetic wave and focus it, as you can see in the bottom left picture. The other way is using a parabolic reflector, whereby the waves are reflected from a sideways view onto the kidney stone. The advantages of the electromagnetic technology, and one of the reasons why it's become the most popular technology nowadays in most markets, is that it's much less noisy. It requires less sedation, and with the improvements in devices, and this is the case for our own Magna and Integra, you can even treat patients without the sedation. Another advantage of this technology is that you don't have a consumable. You can use these coils. They come with a 1 million shock guarantee. The disadvantages of this technology are a smaller focal area. Unfortunately, electromagnetic devices have focal areas which start out at about 5 to 6 millimeters in width, which is much smaller. You will require more shocks per treatment because of this, but at least you don't need anesthesia or sedation to do this, and you will have a higher retreatment rate. So if electrohydraulic technology can treat, let's say, 80% of the patients, has a full fragmentation rate of 80%, let's say, then the electromagnetic technology can vary anywhere from 50 to 70%. of full fragmentation. The last technology is the piezoelectric technology. By passing current through a crystal, you can cause this crystal to rapidly expand and go back to its original shape. The crystals are placed in a parabolic formation. There are a few thousand crystals used at once, and if you cause all these crystals to expand and come back at the same time, you are essentially causing the formation of focused energy. Here you can see the crystal arrangements around hemisphere dish, and each crystal is pointed towards the F2, and this way the F2 receives the energy from all the crystals at one point, and thus a shock wave is observed at F2. One of the disadvantages, of course, of this is that if the crystals break down over time, the efficiency of this generator goes down quite rapidly, and the dishes are very expensive to replace, because you can't just replace a crystal, you have to replace the whole dish. The advantages of the technology is that it's not noisy and it doesn't require almost any sedation. Nowadays it lost that advantage because of the rise of the electromagnetic generation. And of course the disadvantages, as I explained, is the very short crystal life and the high cost of replacing the dishes. The treatment success rate is also very low. So this technology, of course, has only been distributed by a single company for now. The company is Wolf, and usually it is sold to clients who already own Wolf endoscopes. That is the way to enter to sell a piezoelectric lithotripter, because the advantages of the there's no justification for purchasing this lithotripter as compared to any other. This concludes our introductory presentation. We will now take a 10-minute break and come back for presentations on the Integra and Magna systems.